Seniors, what's the best blood sugar for older adults? Know the truth. If your A1C is 6.4 and your doctor assures you everything is perfect, you could unknowingly be on the brink of serious, life-threatening danger. The silent truth is that major medical organizations, including the American Diabetes Association, the Endocrine Society, and leading geriatric specialists worldwide, have quietly updated their guidelines for older adults managing diabetes. What these pivotal changes reveal should compel every senior, every family member to stop, listen intently, and fundamentally reevaluate their understanding of healthy blood sugar. For decades, the ironclad rule was simple: drive your A1C below 7, aiming for 6, 5, or even lower, believing lower is always better. This deeply ingrained belief, however, is now being challenged by groundbreaking studies that followed thousands of seniors for years, uncovering a shocking reality. For many older adults, an A1C pushed below 6.5 is often more perilous than an A1C hovering around 7 to 8. This isn't because high blood sugar has suddenly become safe, but because for seniors, the immediate, devastating threat of severe hypoglycemia, dangerously low blood sugar, can be far deadlier and more immediate than the long-term, slow-developing risks of complications from slightly elevated levels. Your understanding of diabetes management is about to be completely transformed, offering you a path to true safety and a dramatically improved quality of life. You won't want to miss the final habit, or 99% will miss the last tip and will be stuck with dangerous blood sugar levels for life. Imagine waking up to the critical realization that the perfect number your doctor has celebrated could be a ticking time bomb. Consider Robert, a 76-year-old whose A1C of 6.4, a number widely considered ideal, nearly ended his life. One ordinary afternoon, he collapsed in his kitchen from a severe hypoglycemic episode, his head striking the counter with brutal force. Blood poured from a deep gash as he lay on the cold floor, his brain starved of glucose, utterly unable to move or call for help. 20 agonizing minutes passed before his wife found him, barely conscious in a pool of blood. His ordeal wasn't caused by high blood sugar. It was the direct result of blood sugar being dangerously low for someone his age. By the end of this crucial information, you will possess the exact A1C range that current, evidence-based medical guidelines recommend for older adults, a range that could literally save you from suffering the same catastrophic fate. This isn't just about a number. It's about understanding a paradigm shift in senior diabetes care. We won't reveal the precise numerical range just yet, because simply knowing the number without understanding why it's different for older adults can be counterproductive and even dangerous. You need to grasp the profound physiological changes that occur with age, to see the hidden dangers of keeping blood sugar too low in an older body, and to comprehend the complete picture before you can confidently apply these life-saving guidelines. This isn't just theory. It's the difference between thriving and a life-altering crisis. Take a moment to think about someone close to you. Perhaps your mother, who often seems shaky and confused, or your father who experienced a scary episode last month, or a friend who lives in constant fear of eating. These are not minor inconveniences. They are urgent warning signs. This vital information could protect them from a catastrophic fall, a serious injury, or a life-threatening hypoglycemic crisis that could steal their independence and health overnight. This knowledge is too important to keep to yourself. It is a critical insight for anyone navigating diabetes in their later years. Let's delve deeper into Robert's harrowing experience, a story that echoes across countless households, highlighting the urgent need for a new perspective on blood sugar management. Robert had diligently managed his type 2 diabetes for 15 years, ever since his diagnosis at 61 with an A1C of 8.9. His doctor, following standard protocols, started him on metformin and set a clear, conventional goal: get his A1C below 7 to prevent long-term complications like blindness, kidney failure, and nerve damage. Over the years, the approach was a gradual escalation of medication. Metformin doses increased, asulfonylurea was added, and eventually a third medication came into play when an A1C of 7.2 was deemed not quite good enough. By the time Robert reached 76, his A1C had impressively hit 6.4. His doctor was delighted, exclaiming, "This is exactly where we want you. Lower A1C means fewer complications. Keep doing what you're doing." On paper, his blood sugar management looked perfect, a triumph of modern medicine. Yet beneath the surface of these seemingly ideal numbers, something deeply troubling was unfolding within Robert's body, a subtle, insidious danger that went unrecognized. At first, the warning signs were easy to dismiss, manifesting as subtle shifts in his daily routine. In the late afternoons, especially if his lunch was delayed or if he had been more active than usual, Robert would experience a distinct shakiness. His hands would tremble, a light sweat would break out, and his heart would inexplicably pound. These episodes typically vanished within 15 minutes of him eating something sweet. When he described these occurrences at his checkup, his doctor reassured him, "That's just your sugar dropping a bit before meals. It's a good sign your medications are working effectively. Your body is simply adjusting to healthier, lower levels. Just keep glucose tablets handy and ensure you eat regularly." Robert, a compliant patient, followed this advice meticulously. He carried glucose tablets everywhere and adhered to strict eating schedules, believing he was doing everything right for optimal diabetes control. However, these minor drops soon multiplied, escalating beyond mere pre-meal occurrences. Robert began waking at night, drenched in cold sweat, his heart hammering, gripped by a primal terror. He'd stumble to the kitchen, consume something sugary, and within 20 minutes, the terrifying sensation would subside, and he'd feel normal again. His daughter, observant and concerned, noticed a profound change in him. "Dad, you're not yourself," she'd say. "You seem on edge all the time." He attempted to explain the persistent shakiness, the terrifying night sweats, and the constant gnawing anxiety about his blood sugar. Each time he called the clinic, the message remained consistently reassuring. As long as your A1C is good, these symptoms are probably just your body's protective warning system. Keep those glucose tablets handy. Crucially, no one inquired about the frequency of these episodes, nor did they ask how low his blood sugar was actually plummeting. His excellent A1C, a seemingly perfect indicator, tragically masked the growing, life-threatening danger lurking beneath. This is a common pitfall in current diabetes care that you absolutely must avoid. Now, pause and take a moment to reflect on your own situation. In the comments below, share your current A1C and your age using a simple format like A1C 7.8, age 73, or A1C 6.5, age 69. Understanding what people are truly dealing with is essential because what happened next to Robert is not an isolated incident. It's a silent epidemic more common than most people realize, affecting thousands of older adults who are inadvertently overtreated for their age. Your input helps us highlight the urgent need for personalized diabetes management. Then came the day that irrevocably altered everything. It was a seemingly ordinary afternoon. Robert had taken his morning medications as usual and eaten breakfast precisely at 7:30 a.m. Around 2 p.m., while in the kitchen preparing lunch, the familiar shakiness began, but this time, it felt profoundly different, far more sinister. His vision blurred, his thoughts slowed to a crawl, and he couldn't remember what he was doing. He instinctively reached for the counter, but his legs suddenly failed to respond. He fell. The impact was brutal. On the way down, his head struck the sharp edge of the counter, sending him crashing onto the hard tile floor. Blood immediately flowed from a deep gash in his scalp. Though conscious, he was profoundly disoriented, unable to think clearly, unable to move, unable to call for help. 20 agonizing minutes crawled by before his wife returned home from the grocery store and found him, bleeding and deeply confused, lying on the floor. The paramedics, upon arrival, performed a critical, life-saving action that had been tragically overlooked by everyone at the clinic during those months of good A1C readings. They immediately checked his blood sugar. The reading was a terrifying 42. Not just a bit low, but 42 milligrams per deciliter, a level at which the brain literally does not receive enough glucose to function properly, leading to severe cognitive impairment and loss of consciousness. They swiftly administered glucagon, started intravenous dextrose, and watched as his numbers gradually, agonizingly returned to a safe range. As his mind slowly cleared, the lead paramedic delivered a stark, undeniable truth. Your medications are driving your blood sugar dangerously low. They are simply too strong for your body at your age. This was a wake-up call, a realization that shattered years of unquestioning adherence to medical advice. At the hospital, subsequent CT scans revealed a skull fracture and a small brain bleed from the impact of his fall. Robert spent a grueling week in intensive care, followed by another week on the regular ward, recovering from an entirely preventable tragedy. Physically, he was incredibly fortunate. He suffered no permanent brain damage. But psychologically, he was shattered. A man who had always prided himself on his independence and meticulous adherence to medical advice was now terrified. Afraid of his own prescriptions, afraid to be alone in his house, consumed by the fear that the next episode would strike without warning, leaving him helpless once more. Then came the follow-up appointment, an encounter that should send shivers down the spine of every older adult with diabetes. His doctor, reviewing the recent lab results, declared, "Your A1C is still 6.4. That's excellent control. We'll simply adjust your medication timing and re-emphasize regular meals. But we absolutely shouldn't let your A1C climb higher. We've worked so hard to get you to this ideal level." To that doctor, 6.4 at age 76 represented unmitigated success. But to Robert's wife, who had witnessed her husband bleeding on the kitchen floor, it sounded like a chilling, dangerous prescription for disaster. This is where the critical disconnect lies, a truth that medical professionals, and you, must understand. For a man in his mid-70s, especially one on multiple glucose-lowering medications, an A1C in the low 6 range is not automatically excellent. It can be a recipe for catastrophe. Massive observational studies involving thousands of older adults unequivocally show that mortality risk often follows a distinct U-shaped curve. This risk is lowest at A1C values hovering around 7 to 8%, significantly higher at very high values, but equally concerning, also higher at very low values. This crucial evidence has prompted leading organizations like the American Diabetes Association and Geriatric Endocrinology Societies to explicitly state that A1C targets for older adults must be individualized, never rigidly adhering to the same levels used for younger patients. This is a game changer for your health and safety. For Robert, the immediate, tangible risk of another severe hypoglycemic episode, another debilitating fall, another traumatic head injury, another harrowing hospitalization was infinitely more real and imminent than the theoretical risk of diabetic complications that typically take a decade or two to develop. Robert's near-fatal collapse was not an unavoidable tragedy. It was the predictable, tragic consequence of applying diabetes targets designed for middle-aged bodies to an older individual with fundamentally different physiology, altered medication responses, and a completely unique risk profile. Had his care team recognized the urgent warning signs, the frequent shakiness, the terrifying night sweats, the constant anxiety about food as irrefutable evidence of overtreatment, Robert would almost certainly never have hit that kitchen floor. This isn't just a story, it's a critical lesson in senior diabetes care. And blood sugar management. Pause for a moment and reflect deeply. Have you ever experienced a low blood sugar episode that genuinely frightened you? A moment when confusion, sweating, intense shaking, or the inability to think clearly seized control? If you have, take a moment to comment hypoglycemia below. Your body is trying to tell you something profoundly important. Your current treatment strategy may be too aggressive, too dangerous for your current age and unique physiological condition. Ignoring these signals is a perilous gamble with your long-term health and independence. As an older adult, your body undergoes significant, subtle changes that profoundly alter its response to low blood sugar, a phenomenon medically known as hypoglycemia unawareness. For many seniors, the classic, easily recognizable warning signs, intense hunger, trembling, profuse sweating, a rapid heartbeat, become less reliable, often fading or disappearing entirely. Your blood sugar can plummet to dangerously low levels, like 50 or even 40 mg/dL, and you might feel only slightly off, or perhaps nothing at all, until sudden confusion, disorientation, or a complete collapse strikes with terrifying immediacy. Factors like a long duration of diabetes, a history of repeated low episodes, and the natural aging process itself all contribute to this dangerous loss of your body's early warning system. This makes preventing falls and hypoglycemia risk paramount for older adults. Here's a deeper look into why this happens. In younger individuals, when blood sugar drops below approximately 70 mg/dL, the body instantly releases counter-regulatory hormones, such as epinephrine. These hormones trigger those unmistakable, uncomfortable warning symptoms. the shakiness, sweating, and rapid heart rate. While unpleasant, these symptoms serve a critical, life-saving purpose. They alert you to consume carbohydrates before your blood sugar descends into truly perilous territory. However, after years of managing diabetes, especially after experiencing recurrent low blood sugar episodes, these vital warning systems become blunted. The hormonal response weakens, the symptoms fade, and eventually, they may disappear altogether. You lose your early warning system precisely when you need it most, putting you in extreme danger. Furthermore, your metabolism undergoes significant shifts with age. Kidney and liver functions, which play crucial roles in processing medications and regulating blood sugar, tend to decline. Body composition also changes, with a decrease in muscle mass and an increase in fat. Consequently, the same dose of a sulfonylurea or insulin that was safe and perfectly appropriate at age 55 can exert a much stronger, longer-lasting effect at age 75. Medications linger in your system for extended periods, continuing to drive your blood sugar down for hours beyond their intended duration. Compounding this, your body's innate ability to counter-regulate, to release stored glucose when blood sugar drops, also weakens with age. All these cumulative changes mean that older adults face a significantly higher risk of severe, prolonged hypoglycemia and your personal risk-benefit calculation for A1C goals has fundamentally transformed. Consider the stark difference. When you were 50, diligently keeping your A1C below 7 made perfect sense. You had decades stretching ahead, during which persistently high blood sugar could slowly but inexorably damage your eyes, kidneys, and nerves. Preventing those long-term complications was undoubtedly worth the effort and the relatively minor hypoglycemia risk. However, when you reach 75 or 80, the entire situation shifts dramatically. The long-term benefits of ultra-tight blood sugar control may never materialize because those complications typically require 10 to 20 years to fully develop. Meanwhile, the immediate, devastating harms of severe hypoglycemia, falls, debilitating fractures, traumatic head injuries, and even car accidents can strike tonight, tomorrow, or next week. A single severe hypoglycemic episode in an older adult can be catastrophic, initiating a domino effect of health crises. A severe low can trigger a fall that results in a hip fracture, which then necessitates surgery, leading to post-operative complications like pneumonia, potentially culminating in death, all within a matter of weeks or months. It can cause a car accident, trigger a heart attack or a stroke, or inflict permanent brain damage if glucose deprivation is severe enough or lasts too long. These are not abstract theoretical risks. These are immediate, tangible dangers that claim thousands of seniors every single year, profoundly impacting senior health and a quality-of-life diabetes. This urgent reality demands a reevaluation of aggressive or blood sugar management. There's also the invaluable aspect of quality of life to consider. Maintaining an A1C at 6.2 or 6.4 frequently demands constant, exhausting vigilance. Frequent blood sugar testing, rigid adherence to meal timings, a paralyzing fear of eating anything outside a strict plan, and pervasive anxiety surrounding every medication dose. For a younger patient, aiming to prevent complications over 40 years, that trade-off might be acceptable and even necessary. But for a 78-year-old who simply yearns to enjoy meals with family, travel spontaneously, and relax without constant worry, a slightly higher A1C, perhaps in the 7 to 8 range, combined with stable blood sugar and the absence of terrifying lows, can mean a world of difference. It translates directly into more freedom, greater independence, and a vastly improved daily living experience. Think about what diabetes management at very tight targets truly entails in your daily life. It often means meticulously testing your blood sugar 6 or 8 times a day, transforming every meal into a calculation. It means abandoning spontaneity, forcing you to eat at precisely the same times every single day. It means reluctantly turning down invitations to social gatherings or travel opportunities because you're consumed by worry about how to manage your blood sugar in unfamiliar situations. Ultimately, it means a life dominated by constant fear and anxiety. For many older adults, this relentless level of restriction and worry, ironically, reduces their quality of life far more significantly than a slightly elevated, yet stable blood sugar level ever would. This is why a new approach to diabetes guidelines is so critical for healthy aging. So, what exactly do the latest guidelines recommend? Major diabetes organizations, including the American Diabetes Association, now unequivocally recommend that A1C goals for older adults be individualized. This means taking into account your overall health status, your realistic life expectancy, the presence of any existing complications, and most critically, your personal risk of hypoglycemia. These targets should not simply be copied from younger patients as a one-size-fits-all solution. The American Diabetes Association's standards of medical care specifically categorize older adults into different groups, each requiring a tailored, nuanced approach to diabetes management. For healthy older adults who maintain intact cognitive and functional status, these guidelines suggest considering similar targets to younger adults, but with an unwavering and meticulous attention to hypoglycemia risk. This means vigilance, not aggressive lowering. For those with multiple coexisting chronic illnesses or moderate cognitive or functional impairment. Now, list stringent A1C goals are explicitly deemed more appropriate and safer. And for those in long-term care or with very limited life expectancy, the focus should shift entirely away from rigid A1C targets and squarely toward preventing symptomatic hyperglycemia, high blood sugar that causes symptoms, and most importantly, avoiding the immediate and severe dangers of hypoglycemia. This represents a monumental shift in A1C goals and senior diabetes care. Many expert guidelines now propose that for healthy, independent older adults with few other medical problems and no history of severe hypoglycemia, reasonable A1C goals are often around 7.00 to 7.5%. For those with multiple medical conditions, some functional limitations, or a higher predisposition to hypoglycemia, even more relaxed goals of approximately 7.5 to 8.0% are frequently appropriate. For very frail seniors, those with a limited life expectancy, or individuals with a documented history of severe hypoglycemia, some guidelines even allow A1C targets of 7.5 to 8.5% or even higher, with the paramount priority being the prevention of dangerous lows and the preservation of their overall quality of life. This is a crucial understanding for anyone concerned with older adults' diabetes and medication adjustment. Let's be absolutely crystal clear about the profound implications of this information. These are not fringe opinions or radical alternative medicine recommendations. These are the official, evidence-based guidelines issued by the most mainstream and traditionally conservative medical organizations in the world: the American Diabetes Association, the Endocrine Society, and the American Geriatric Society. These highly respected organizations are explicitly stating that for a significant number of older adults, A1C targets should be higher than the traditional below 7 goal. They are making this declaration because the overwhelming scientific evidence unequivocally demonstrates that it is safer, leading to better outcomes and a significantly enhanced quality of life. These aren't personal opinions. These are established patterns derived from robust, evidence-based guidelines published by leading medical authorities. Your own personal target for blood sugar management must always be decided in collaboration with your own doctor, based on your complete medical history and current health status. However, these guidelines illuminate one undeniable truth. If you are in your 70s or 80s, taking multiple diabetes medications, and your A1C is in the low 6s while you are simultaneously experiencing frequent symptoms of low blood sugar, that is, excellent control, it is a critical warning sign that your treatment may be overly aggressive and inherently dangerous. It's time for an informed conversation with your healthcare team about your A1C goals and overall senior health. To illustrate what this looks like in a real-life scenario, let's consider Sarah. Sarah, 72 years old, was active and took immense pride in meticulously following her doctor's advice. For years, her A1C consistently hovered around 7.8. Her doctor, aiming to get her under the traditional 7% mark, added another medication to her regimen. 6 months later, her A1C dropped to 6.9, and her doctor was understandably pleased. However, Sarah felt anything but pleased. She felt utterly exhausted. The preceding months had been plagued by terrifying, shaky episodes in late afternoons, waves of debilitating anxiety before dinner, and on 2 occasions, her husband had to physically catch her arm as she wobbled dangerously while standing up. One night, she awoke drenched in a cold sweat, her heart pounding in a panic, discovering her blood sugar was a perilous 58. After eating something sweet, she lay awake for an hour, too frightened to return to sleep. At her follow-up appointment, she desperately tried to explain, "I feel awful, doctor. I'm actually scared to drive now." Yet her doctor, focused solely on the number, pointed to her A1C. "But look at this, Sarah. You're finally under 7. This protects you from eye and kidney problems. We just need to fine-tune your meals." Sarah left the appointment feeling unheard, dismissed, and, most importantly, still dangerously overtreated. This is a common and dangerous trap in older adults' diabetes by Peden care. Contrast Sarah's experience with Helen, age 78, who faced a similar struggle but achieved a dramatically different positive outcome. Helen's A1C was a perfect 6.7 on paper. In reality, she was waking 3 nights a week, drenched in sweat, gripped by terror, stumbling through her house to consume glucose tablets. Her days revolved around rigid meal schedules and a constant, pervasive worry about impending lows. When she brought these serious concerns to a new doctor, instead of merely celebrating her seemingly ideal A1C number, he took a different, more empathetic and evidence-based approach. He asked for a 2-week log of her blood sugar readings and symptoms. That meticulously kept log revealed the stark truth that her A1C had so cunningly hidden. Multiple readings plummeting into the 50s and low 60s, particularly overnight and in the late afternoon. Based on this undeniable evidence, her new care team strategically reduced one of her high-risk medications. Her A1C subsequently rose to 7.4. The terrifying low blood sugar episodes ceased entirely. She finally slept soundly through the night, her energy levels returned, and she happily rejoined her beloved book club and attended her grandchildren's games without fear. Here's the crucial takeaway. Nothing inherently magical happened at 7.4. What fundamentally shifted was the delicate balance between benefit and harm in her blood sugar management. At 6.7, Helen's diabetes appeared perfectly controlled on paper, but it was actively wrecking her sleep, eroding her confidence, and jeopardizing her safety. At 7.4, she still maintained reasonable, safe control, but the immediate, devastating danger of severe lows was dramatically reduced. For a woman in her late 70s, that profound shift in safety and well-being is far more valuable and life-affirming than a perfect number that comes with constant, debilitating fear and anxiety. This is the essence of smart, senior diabetes care, and prioritizing quality of life diabetes. Now let's make this personal. Again, in the comments section, share your age and whether you have any other significant medical conditions. Please use a format like 74, heart disease, or 68, healthy, or 82, frail. This helps paint a clearer picture of the diverse challenges people are facing and allows us to reinforce the most relevant guidance for different health profiles. Your honest input empowers us all. So, how do you translate this profound understanding into actionable steps that can protect your health and enhance your life? The first critical step is to diligently collect the precise information your doctor needs for 1 to 2 weeks. This isn't about overwhelming yourself with constant monitoring, but about gathering meaningful strategic data. Check your blood sugar at key times. First thing in the morning, fasting, before 1 or 2 main meals, occasionally 2 hours after eating, and crucially, right before bed. You don't need to test every single hour. You need targeted, insightful data. Each time you test, make a note of 3 essential pieces of information: the numerical reading, the exact time of the reading, and most importantly, how you genuinely feel at that moment, e.g., shaky, sweaty, confused, fine, energetic. Also, record if you've just exercised vigorously or if you missed a meal, as these factors directly impact your levels. If you ever see numbers below 70 mg/dl, make sure to circle them prominently. These are definitive low blood sugar episodes, and they are urgent warning signs. If you observe numbers below 80 mg/dl and simultaneously feel unwell or off, highlight these readings. For older adults, even borderline lows can be dangerous, especially if they occur repeatedly or, even more perilously, during the night while you're sleeping. Additionally, meticulously write down any concerning events you experience, any falls, any times you felt so overwhelmingly weak that you had to sit down immediately, or any episodes of confusion or difficulty thinking clearly. This comprehensive log is your powerful advocacy tool. Then, bring this meticulously compiled log to your next appointment. When your doctor confidently states your A1C is good, you now have the tools and confidence to respond effectively. You can say, "Doctor, I want to show you what it actually takes for me to maintain this A1C. Here are my detailed blood sugar readings and symptoms from the past 2 weeks. As you can see, I've had readings dropping into the 50s, and I've experienced nights of severe sweats and profound confusion. I am genuinely concerned that my current treatment regimen might be too strong, too aggressive for my age and current health status." This shifts the conversation dramatically. Instead of engaging in a contentious argument about a single number, you are presenting a complete, undeniable picture. Your A1C, combined with concrete evidence of frequent hypoglycemic episodes and, crucially, how you genuinely feel day to day. You are reframing the issue to focus squarely on two paramount priorities in modern diabetes care for older adults: your safety and your quality of life. A reasonable, well-informed clinician will recognize that an A1C in the low sixes, coupled with frequent and distressing symptoms of hypoglycemia, is not a sign of good control. It is irrefutable evidence of overtreatment, a dangerous imbalance in medication adjustment. Here's exactly what you can say to your doctor, empowering you to initiate this vital conversation. You might begin with, "I've been reviewing the current guidelines from the American Diabetes Association regarding A1C targets for older adults. I understand that for people my age, particularly those experiencing hypoglycemia, targets of 7 to 8% may actually be safer than very low targets. Could we please discuss whether my current target is truly appropriate given my age and the symptoms I've been experiencing?" This approach is respectful, yet firm, grounded in current medical consensus regarding reishi diabetes guidelines and of older adults' diabetes. Instead of directly stating, "I want my A1C higher," which might sound non-compliant, try phrasing it this way: "Doctor, my primary goal is to reduce my risk of severe hypoglycemia and prevent dangerous falls. I am seeking treatment that is appropriately matched to my age and body's current needs. Many current guidelines now acknowledge that A1C targets of 7 to 8% are often safer for older adults like me. Can we explore adjusting my medications to help me achieve a safer and more sustainable range?" This is a powerful, evidence-based approach to your own blood sugar management. You can also ask very specific, targeted questions about your current medications. Are any of the drugs I'm currently taking particularly prone to causing dangerous lows at my age? Could we explore simplifying my regimen or switching to alternative options that carry a significantly lower hypoglycemia risk? It's important to understand that older sulfonylureas, such as glyburide and glipizide, are well-known culprits for inducing severe lows in seniors. These medications essentially force your pancreas to release insulin regardless of your actual blood sugar level, which can lead to unpredictable and dangerous drops. Certain insulin regimens, especially if doses haven't been meticulously adjusted as you've aged, can also pose significant problems. In contrast, newer medication classes, such as SGLT2 inhibitors, SGLT1 receptor agonists, as mentioned in the transcript, GLP-1 receptor agonists, and DPP-4 inhibitors, generally carry a much lower risk of hypoglycemia when used appropriately. While these newer options are not suitable for everyone and have their own unique side effects and costs, simply discussing them with your doctor signals that you are actively seeking safer alternatives, not abandoning your diabetes management altogether. This proactive approach ensures you are pursuing the best senior health strategies available. If, after a thoughtful, open conversation and presenting clear evidence from your log, your clinician still expresses reluctance to consider adjusting your targets, you have a right to press further. You can politely but directly ask, "Doctor, what specific evidence or guidelines are you relying on to determine that my current A1C target is appropriate for someone my age with my particular health status? Could you show me the official guidelines that explicitly support this aggressive target for older adults? This approach gently but firmly challenges them to justify their recommendations based on current, up-to-date evidence, rather than relying on outdated habits or generalized targets. If, after all these steps, your clinician still refuses to consider adjustment, despite thoughtful conversation and compelling evidence, it may be time to seriously consider seeking a second opinion. Ideally, this second opinion should come from a healthcare professional with specialized experience in geriatrics or diabetes management, specifically in older adults. You are not being difficult or non-compliant by advocating for yourself. You are simply asserting your right to receive evidence-based care that is appropriately tailored to your age, your unique physiological situation, and your overarching goals for safety and quality of life. This is paramount for effective diabetes management in a PAC and Meister healthy aging. Let me share one more compelling story before we conclude, highlighting the transformative power of this individualized approach. Michael was 81 years old, and his A1C was a respectable 6.8. His doctor was quite pleased with this excellent control. However, Michael had inexplicably lost 15 pounds over 6 months, felt persistently weak, and was utterly exhausted. He had stopped attending his beloved card games and had become increasingly isolated from his friends. His daughter worried he was sinking into depression. When his blood sugar log was finally reviewed, the insidious problem became immediately clear. He was consistently running between 60 and 90 milligrams DL for most of the day. While technically good control by old standards, for an 81-year-old, those numbers were simply too low. His body was enduring chronic, mild hypoglycemia, not dramatic episodes, but a constant, subtle glucose deprivation to his brain and muscles, slowly sapping his vitality. We strategically reduced his medications. His blood sugar levels gradually came up to a more stable range of 100 to 150 mdl, and his A1C gently rose to 7.2. Within a mere 3 weeks, Michael underwent a dramatic transformation. His energy surged, he gained back a healthy 8 pounds, he eagerly returned to his card games, and joyfully reconnected with his friends. His previous doctor was initially upset, believing we had let his diabetes get worse. But Michael's diabetes hadn't gotten worse. His quality of life had dramatically, profoundly improved. He was truly living again. That ultimately is what all this critical information is truly about. Living your life to the fullest, enjoying your remaining years with vitality and independence, not sacrificing everything for a single number on paper that may not even be appropriate or safe for your age and specific situation. This is the ultimate goal of sensible senior diabetes care. And a quality of life diabetes. So, whether you are an older adult living with diabetes or you care for one, here are the crucial takeaways you must embed into your understanding of blood sugar management. First, those very low A1C targets that made perfect sense and were appropriate at age 40 can become inherently risky and dangerous at age 75. Second, your symptoms, the shakiness, the night sweats, the confusion, the falls, matter just as much, if not more, than your isolated lab results. They are your body's urgent warning signals. Third, for a vast majority of seniors, especially those managing other medical conditions, the safest and most beneficial place to be is in the middle. Not wildly high, not aggressively low, but a moderate, stable range that effectively protects against both symptomatic hyperglycemia and, crucially, life-threatening hypoglycemia. The true goal of diabetes care in older adults is not an elusive, dangerous perfection measured by an arbitrary low number. Instead, it is unwavering protection. Protection of your precious brain so you can think clearly, maintain your cognitive function, and enjoy mental sharpness. Protection of your muscles and bones so you can stand, walk confidently, and maintain your independence. Protection of your kidneys and heart, yes, absolutely, but never ever at the devastating cost of life-threatening lows that can steal your health and autonomy in an instant. Use your story, your meticulously collected blood sugar numbers, and your empowered voice. Bring your detailed log to your appointments. Clearly describe your symptoms and how they impact your daily life. Demand A1C targets that genuinely fit your age, your physical reality, and your personal goals for living well. And remember, never, under any circumstances, change your medications on your own. Every adjustment must be made in close collaboration with a compassionate and knowledgeable clinician who deeply understands that for older adults, safe and steady blood sugar control is unequivocally better than aggressively low and dangerously unstable levels. This informed approach is fundamental to healthy aging and preventing the hidden dangers of inappropriate diabetes management. Subscribe. Which advice will you start applying today?